Good afternoon and welcome. We're going to give it just a couple of minutes so that others can join us. We're going to give it just one more minute and then we'll get started. Good afternoon, everyone, and thank you for joining. I'm Cassandra Lage, and I'm going to tell you a little bit about myself. I've been in the healthcare industry for over 20 years. Currently, I serve as the Executive Director of Patient Access for the Sylvester Comprehensive Cancer Center, part of the University of Miami. I earned my MBA in healthcare sector, as well as a Six Sigma Green Belt and a Champion Belt, all from the University of Miami. I serve on the Certification Committee and the South Regional Educational Committee, also on the Women's Florida Leadership Committee, all part of HFMA, and I earned my CHFP. Today, we are going to be covering the second portion of Unit 2. And last week, we covered from 2.1 to 2.3. Today, we're going to cover from 2.4 to 2.7. A few housekeeping rules. Please keep your cameras off and remain on mute during the presentation. At the end of the presentation, we'll have time for questions where you'll be able to unmute yourself and ask any questions. Should you have any questions during the presentation, please use the chat to ask them. As a reminder, it's very important that you sign into your e-learning with HFMA and review your modules. There's a significant amount of information that we can't review during these presentations just because of time. So it's very, very important that you don't rely only on this, as you will need to do your own studying. And I strongly recommend that you take the quizzes that are embedded throughout them so that you are better prepared for the actual test. Attending these sessions alone will not be enough to pass the test, so please make sure you make time to complete the modules. And so in this section, we're going to discuss the basic billing rules for the major health plans. We'll also have an overview of the basis of billing features and benefits and minor claim payers and plans. Many people under the age of 65 receive health insurance through an employer. Others buy their own insurance through the individual insurance market or the insurance marketplace, also known as the insurance exchange, created by the Affordable Care Act. In addition, there are federal and state health insurance programs available to qualify individuals. Medicare is a government-sponsored program which is financed through taxes and general revenue funds. Medicaid is a federally aided state-operated program to provide health and long-term care coverage for low-income individuals or families. Tricare, formerly known as CHAMPUS, is a healthcare program of the United States Department of Defense Military Health System. Indian Health Services, IHS, is an agency within the Department of Health and Human Services, which is responsible for providing federal health services to Native Americans. The Blue Cross and Blue Shield brands are the nation's oldest and largest family of health benefits companies and the most recognized branch in the health insurance industry. Commercial indemnity plans over almost all services without authorization requirements. So they offer almost all of the services without requiring authorization, and I don't think we see too many of those anymore. A self-funded plan where the cost of medical care are borne by the employer as a pay-as-you-go on a pay-as-you-go basis. Comprehensive healthcare plans that attempt to reduce costs through contractual agreements with providers and through care management initiatives. The Medicare insurance programs has features unique from other health plans. It is government sponsored and financed through taxes and general revenue funds. Medicare Part A benefits provide coverage for inpatient hospital services, skilled nursing care, and home health care. Medicare Part B benefits are available for outpatient and professional service coverage, but the beneficiary must pay a monthly premium for the additional coverage. Medicare Part C, known as Medicare Advantage, is a type of managed care plan that includes both Medicare Part A and B benefits, and it may also include Part D benefits. Medicare Part D is known as a prescription drug coverage program. It consists of private insurance plans that are reimbursed by the Centers of Medicare and Medicaid Services, or CMS, and benefits provided to Medicare beneficiaries. Beneficiaries may enroll in a prescription drug plan or a Medicare Advantage plan, the Part C, which may also include prescription drug benefits. Medicare Part A benefits consist of benefit periods. The beneficiary remains in the same benefit period until he or she is hospitalization free or skilled nursing care free for 60 consecutive days. A deductible is due each time a beneficiary is readmitted after remaining hospitalization free and or skilled nursing care free for 60 consecutive days. Medicare uses the concept of a full coverage period for payment. It will pay full benefits for up to 60 days in a benefit period. The full 60 days renew with each new benefit period. After the 60 full days are used, the beneficiary has 30 coinsurance days. When a beneficiary uses the coinsurance days, a daily out-of-pocket expense equal to 25% of the current deductible amount is due from the patient. After the 60 full and 30 coinsurance days are used, the beneficiary may opt to use 60 lifetime reserve days. The daily out-of-pocket for each lifetime reserve day used is 50% of the current deductible amount. The lifetime reserve days are used once in a lifetime and never renewed. So once you go through those, you don't get any back how you would with the others. After 60 full coverage days, 30 coinsurance days, and the 60 lifetime reserve days are used, the beneficiary qualifies for no further Part A benefits. If the patient has Part B coverage, Part B can be billed for services covered in the outpatient setting. Medicare Part B is financed through beneficiary premiums and general revenues. It provides coverage for physician services, outpatient services, and other health professions. Medicare Part B has an annual deductible, and the beneficiary is responsible for coinsurance payment for all Part B covered services, excluding diagnostic laboratory services. Coinsurance amounts for services paid under the outpatient prospective payment system, or the OPPS, are determined by federal regulations and change as the OPPS payment system is updated each year by CMS. Hospital inpatient and outpatient services are submitted to Medicare and Medicare Advantage plans electronically using the 837I format. Physician services are submitted electronically using the 837P format. See course 3.5, claim form requirements, edits, and EDI for more information on those forms or formats. To be eligible for Medicare reimbursement, claims must be filed within 1 calendar year of the date of service. Medicare systems will reject or deny claims that are not received within the specified time frame. Medicare Advantage plans claims must be filed within the specific health plan's qualifying time limit per the provider contract. And then Tricare. Medicaid is federally aided, state-operated, and administered program to provide health and long-term care coverage for low-income individuals or families. A state may elect to contract with other health plans to offer one or more Medicaid managed care plans as an alternate to the traditional Medicaid coverage. Eligibility for Medicaid benefits expanded in January 1st of 2014 through a provision of the Patient Protection and Affordable Care Act, as states were provided additional funding if benefits were extended to individuals under 65 years of age with incomes of up to 133% of the federal poverty level. In addition, for the first time, low-income adults without children were guaranteed coverage through Medicaid. Not every state has elected to expand Medicaid coverage in this manner. To participate in Medicaid, federal law requires states to cover certain groups of individuals, such as low-income families, qualified pregnant women and children, and individuals receiving supplemental security income are some of the examples of the mandatory eligibility groups. States have additional options for coverage and may choose to cover other groups, such as individuals receiving home and community-based services and children in foster care who are not otherwise eligible. Tricare, formerly known as CHAMPUS, is the Uniform Services Healthcare Program for active duty service members and their families, retired service members and their families, members of the National Guard and Reserve and their families, survivors, and others who are eligible. Tricare Prime, which is an HMO type program where military treatment facilities are the principal source of the healthcare. With a point of service or POS option, this program covers active duty military and their families. Tricare Standard and Extra A fee-for-service plans are available to all non-active duty beneficiaries through the United States. This program includes outpatient deductibles and co-insurance requirements. The type of provider seen determines which option is used. When visiting a non-network provider, the standard option is used. The extra option is used when visiting a network provider. The Tricare supplement to the Medicare program. This program is only available to Medicare eligible individuals who are also enrolled in Medicare Part A and B benefits. So these are a few of the key points. And I'll give you a second to go ahead and read that. And then we're going to go into one of our polling questions. So get ready to read the question and select an answer. Which option is a federally aided state program for health coverage? All right, we're going to go ahead and wrap up and see what you selected. It looks like most of you were between A and C, and the correct answer is C. Medicaid is for low-income individuals or families. Eligibility for Medicaid benefits expanded effective January 1st of 2014 through a provision of the Patient Protection and Affordable Care Act, as states were provided additional funding if benefits were extended to individuals under the age of 65 with incomes up to 133% of the federal poverty level. So now we're going to go into 2.5, health plans and managed care. And in this course, we're going to address the various types of managed care health plans and the requirements for managed care health plans. Today, more than half of all of Americans who have health insurance are enrolled in some kind of managed care plan. Managed care plans have agreements with certain doctors, hospitals, and healthcare providers to give a range of services to the plan members at reduced costs. These plans usually include provisions for utilization controls such as pre-certification for admissions and high-dollar outpatient procedures. The types of managed care plans, along with their definitions, are health maintenance organization, or HMOs, any healthcare insurance plan that provides or insures comprehensive health maintenance and treatment services for an enrolled group of persons based on a monthly fee. HMOs will give the beneficiary a list of doctors from who to choose a primary care doctor. This doctor coordinates a beneficiary's care, which means that generally the beneficiary must contact that doctor to be referred to a specialist or obtain prior authorization for non-emergency hospital services. Under an HMO contract, the plan only covers approved services provided by HMO providers. If the patient goes outside of the HMO, the patient is responsible for the total charges. Preferred provider organizations, PPOs. This form of managed care is the closest to an indemnity plan. It is the health plan where the employer and the health insurance carrier contract to purchase healthcare services for covered beneficiaries from a selected group of participating providers. Participating providers agree to abide by utilization management and other procedures implemented by the PPO, and agree to accept the PPO's reimbursement structure and payment levels. PPO coverage permits members to use non-PPO providers, although higher levels of coinsurance and or deductibles routinely apply when services are provided by non-participating providers. Exclusive provider organizations, or EPOs, are similar to PPOs in their organization and purpose, but unlike PPOs, they limit their beneficiaries to participating providers for their healthcare services. For example, beneficiaries covered by an EPO are required to receive all of their covered services from providers that participate in the EPO, similar to how HMOs do or work. Point of service plans, or POSs. Many HMOs offer an indemnity type option known as a POS. The primary care doctors in a POS plan usually make referrals to other providers in the plan, but in a POS plan, members can refer themselves outside of the plan and still get some coverage. If the doctor makes a referral out of the network, the plan pays all or most of the bill. If the patient wants to use a provider outside of the network and the service is covered by the plan, the patient will have a higher coinsurance or higher financial responsibility. Medicare Advantage plans are health plan options that are part of the Medicare program. A patient must have both Medicare Part A and B benefits to be eligible for a Medicare Advantage plan. The patient continues to pay his or her monthly Part B premiums to Medicaid, and in addition, the patient may have to pay a premium to the Medicare Advantage plan for the extra benefits that they offer, which can include prescription drug coverage. Patients who join a Medicare Advantage plan generally get all of their Medicare covered healthcare through that plan. Medicare Advantage plans include the following types of plans: Medicare Health Maintenance Organizations, or HMOs, preferred provider organizations, PPOs, private fee-for-service plans, and Medicare Special Needs plans. Medicare Advantage plans replace Medicare's traditional fee-for-service plans. Patients who join a Medicare Advantage plan will receive a health insurance card from the plan they select, and this card must be used to access healthcare instead of their Medicare card. And this is important because I still find that some patients will bring you their Medicare card and not the insurance plan card, and it's really important that we enter the information for the insurance card. Most plans provide extra benefits and lower out-of-pocket amounts than original Medicare, but with some plans like HMOs, the patient may be required to see doctors who belong to the plan or go to certain hospitals to receive the covered services. And so, continuing with managed care plans, Medicaid HMO plans, in many states, people covered under the Medicaid program are required to join managed care plans. Medicaid care plans focus on preventative health care and providing enrollees with a medical home for themselves and their dependents. Medicaid manages care plans must ensure that recipients have access to all medically necessary services that are covered by Medicaid, but use the HMO managed care concepts to coordinate care for utilization management. Capitation is a method of payment to healthcare providers whereby a fixed amount is paid per enrollee to cover a defined set of services, such as physician visits, routine diagnostic testing, etc., over a specified period of time, regardless of the actual services provided. So they get this amount, whether they provide a little bit of services or a lot of services. Consumer direct health plans, where the consumer directed health plans, directed health plans, a subscriber agrees to a high initial deductible, typically in the $2,000 to $5,000 range, in return for lower premiums. In addition, these plans typically are attached to a health savings plan, which allows the employee to save pre-tax dollars in an account that can be used to pay for the higher deductible and co-insurance liabilities. An advantage of these accounts is that there is no requirement to spend these funds within a given calendar year, and any remaining funds go with the employee should the employee leave the current employer. The various tools and how they're used to manage utilization are listed here. Pre-certification or pre-authorization is routinely required for elective hospital admissions. So concurrent reviews can be planned and discharge planning can be started on high-dollar outpatient services, including surgeries, to monitor and or control utilization by evaluating the appropriateness, necessity, and quality of the requested services. Referrals. Referrals are documents completed by a primary care physician that notify an HMO insurance plan that he or she is sending a patient to a subspecialist or specialist for medical care beyond the scope of the primary care physician. The referral notifies the insurance that the primary care physician has recommended and is coordinating care. Notification is a requirement whereby providers notify the insurance plan of an insured patient that an insured patient is requesting medical services. Insurance companies usually require notifications so that their case management can provide utilization management services as required. Days approval, continued stay review, and additional days approval. A utilization review nurse is assigned to the case, and based on the admission diagnosis and clinical data, the managed care health plan authorizes a length of stay and will not pay for services beyond the approved days unless additional days are authorized. Site of service limitations. Many health plans have developed care plans for common diseases and procedures. The care plans will include appropriate settings for the care and will only pay for the services in an approved setting. An example would be that certain surgical procedure will only be paid as an outpatient service. And you can think of, for example, a colonoscopy or a cataract eye surgery. And so some key points. Managed care plans have agreements with physicians, hospitals, and other healthcare providers to offer a range of services to the plan members at a reduced cost. Managed care plans include your HMOs, your PPOs, EPOs, POSs, the consumer direct health plans, the Medicare Advantage plans, and your Medicaid HMO plans. Managed care health plans use prior authorizations and utilization management review to determine if care is medically necessary. These procedures and tools include pre-certification or pre-authorization, referrals, notifications, site of service limitations, case management, and discharge planning. And so this leads us to one of our polling questions. Which option is not a specified managed care requirement? All right, let's see what you answered. So it looks like the majority selected discharge planning, and some selected the preferred provider organization, or the other large chunk of us. So the correct answer is C, preferred provider organization. PPO is a form of managed care, which is the closest to an indemnity plan. PPO is not a specific managed care requirement. It's a health plan where the employer and the health plan contract to purchase healthcare services for covered beneficiaries from a selected group of participating providers. And now we've made it to section 2.6. In this course, we're going to cover the principles of price transparency, the role of price estimates in patient financial care, and how pricing information is used to prepare and present price estimates. So what is price transparency? I'm sure everyone's heard quite a bit about price transparency lately. So getting to the price of services is a challenge for both patients and providers. Price is defined as the amount actually paid for the health plan and or the patient. In other words, the amount that they pay for a specific service. This is very different from either cost or charges. The price a patient pays for healthcare services depends on the healthcare insurance that he or she has or doesn't have. If a patient has health insurance, generally the patient shares in the total price of the form of the deductible, co-payment, or co-insurance. In addition, health plans often contract with hospitals, physicians, and other healthcare providers to form a provider network for its members or subscribers. The price for in-network services will be lower than the price for the same service if it's received in an out-of-network setting. With the advent of high deductibles health plans, consumers and patients are requesting price and quality information as part of determining where they will receive care. In other words, now they're starting to shop around. Therefore, providers have developed processes and employ technology solutions to respond to these requests. The first component of pricing determination is verification of the patient's insurance eligibility and benefits. Most often, this information is obtained through a real-time electronic transaction with the health plan. The second component of determining a price is to identify the services or tests involved. The clinical information needed to determine a price includes the specific service, the patient type, a diagnosis, a procedure code, and any anticipated follow-up care. The health plan responds to a verification inquiry typically containing the following information, which is needed to develop a price estimate: a confirmation of the consumer or patient's eligibility for coverage, details of coverages and limitations, including site or service restrictions, such as eligible lab draw locations or number of therapy visits authorized, network status, authorization or referral requirements, detailed statuses of contracted deductible, co-payment, co-insurance, and maximum out-of-pocket limitations. If your organization has deployed a technology solution to create price estimates or not, you may have a worksheet or other tools to guide you through determining the information needed to respond to a price request. So first we would verify the insurance coverage that will be used for the service, including eligibility and benefit details. Then we document the current status of the deductible and or any co-insurance amount, because you want to make sure to capture that patient's out-of-pocket expenses. Then you need to identify the contract terms between your organization and the health plan. For example, are inpatient cases paid by MSDRGs, 8% of charges, preset case rates, bundled services, etc. And then the third circle, you obtain the total charges for the hospital portion of the case, concurrently identify any additional providers who may be involved, for example, sometimes anesthesia, and note their in-network or out-of-network status. And next, you'll need to apply the benefit information to the charge information, apply the payment methodology to the total charges. The price estimate should be presented in a format that is easily explained to the patient. In addition to the price estimate for hospital service, the financial conversation should also inform the patient that physician services are or are not included. The in-network or out-of-network status of the physician should also be communicated to the patient. And so here are some of the key points from what we just covered. The importance of applying price transparency principles to the development of information necessary. Healthcare is different from commodities that are more often purchased. So consumers do expect that providers will inform them of their responsibility or their financial responsibility for the service. And coupling the price estimates with patient financial communication is the best practice, and it allows providers to provide a high quality level of financial care to our patients. So as we wrap up this section, we're going to go now to a polling question. So get ready to log your answers. What is the first component of a pricing determination? All right, let's see what answers you selected. And it looks like the vast majority went with B, which is the correct answer, verification of the patient's insurance eligibility and benefits. Most often, this information is obtained through real-time eligibility or an electronic transaction with the health plan. The health plan response to the verification inquiry typically contains the following information, which is needed to develop a price estimate: confirmation of the patient's eligibility or coverage, details of the coverage and limitations, including site or service restrictions such as eligible lab draw locations or the number of therapy visits that will be authorized, and the network status. So 2.7 covers, section 2.7 covers patient financial communication. In this course, we'll be covering the patient financial communication best practices through concepts of financial counseling. Patient financial care concepts, which include negotiating account resolution, identifying and initiating financial assistance process or charity, pursuing time of service collections, and achieving account resolution. Financial counseling is done to help the patient understand his or her health plan coverage and financial responsibility for services, for healthcare services received. Components of financial counseling include informing the patient of the hospital's financial policies, explaining health plan benefits, discussing financial responsibility, assessing the patient's ability to pay, and reviewing payment alternatives with the patient so appropriate resolution of the health care financial obligation is achieved. Patient liabilities are comprised of two types of self-pay dollars. One type is pure self-pay, where the patient is uninsured and is responsible for the total cost of the healthcare services. So they're going to cover the entire bill on their own. The second type is the self-pay balance after insurance. These amounts are the costs that the patient's responsible for, which is determined by employers and health plans and includes plan deductibles, co-insurance amounts, and co-payment amounts, and any non-covered services as identified by the health plan or employer. Patient financial communication or best practices developed by HFMA task force of industry leaders addresses patients' communications regarding health plan coverage, financial counseling, financial responsibility for service, and unpaid balances. A complete copy of these best practices can be found in the resources tab of this program. They also address the most appropriate ways to conduct financial interactions at every point in the patient-centric revenue cycle, from the moment emergency or non-emergency medical services are scheduled or a patient arrives for a non-scheduled service or elective or non-elective procedure. Compliance guidance is also included, as well as annual training requirements, technology assessments, and annual reporting to the C-suite on the topic. Excuse me. We discussed creating estimates in the last section, so that should provide you with the ability to have the conversations on patient liability, including past due balances. Options are full payment, short-term payments, or potentially a bank loan program. If financial resolution cannot be obtained through any of the options provided, then financial assistance screening should be initiated through Medicaid and hospital financial assistance programs. Medicaid eligibility screening may occur through a variety of approaches, all designed to qualify patients for medical assistance. Typical approaches are presumptive eligibility, Medicaid expansion in some states via the established electronic process. County or state workers maintain an office in the hospital and meet with the patient. An outsourcing firm meets with referred patients and helps them complete the application process. Internal staff within the patient access department screens the patient's application based on current Medicaid guidelines and refers cases which qualify or are borderline eligible to the local Medicaid office for processing. Financial assistance is offered when the responsible party does not have the ability to pay and does not qualify for Medicaid assistance. This is often based on a sliding scale discount amount up to 100% discount based on the patient's financial status. Each provider determines the amount of the discounted or free care. However, the basis for qualification is typically the federal poverty guidelines, published annually by the federal government. Each provider must comply with the rules included in the Affordable Care Act. Financial assistance represents an account resolution option which must be managed within the guidelines set by the provider. Communicating effectively with patients can be complicated by the negative implication of the use of the term charity. Presenting financial options and provider-based assistance opens a dialogue without the negative effects of the charity term. Patients who are either underinsured or uninsured are screened for potential financial assistance. The provider's financial assistance policy and application are presented to the patient. The financial counselor may assist the patient with the application. Information requested typically includes 4 categories of information, which are demographic, income, assets, and expenses. Part of a successful time of service collection program involves training staff on how to request payment and conduct the conversation in a way that minimizes barriers to payment. Scripts are an effective staff tool that provides guidance on how to conduct the interview, ask for payment, and overcome payment obstacles. I have to say that I can remember being new at it, and the scripts were very helpful. And after you go doing it for a few times, you become more comfortable with what you're saying. And I think that really translates to how you interact with the patient. And of course, presenting it as that you're there to help is also very important. I think it's very helpful. So here on the slide, we have some of the things that are important to include in your interaction, including greeting, the way you greet your patient, including ensuring that you introduce yourself with your name. Make sure that it's a convenient time for them to speak with you. Always start by asking for your payment in full. I do recommend that. And then from there, you'll be able to gauge if they're able to pay part of it, all of it, none of it, etc. And then key points for the section are the components of financial education and the financial components of financial counseling so that you obtain a financial resolution. So with wrapping up this section, we're going to go ahead and move forward to our polling question. what is the purpose of financial counseling? And I'll give you a couple of minutes to review and select your answers. These are longer answers, so I'm going to give you a little longer. Okay, let's see what you selected. Wow, 100% selected C, and that is the correct answer. Way to go, guys. That's great. So components of financial education include informing the patient of the hospital's financial policies, explaining health plan benefits, discussing financial responsibility, assessing the patient's ability to pay, and reviewing payment alternatives with the patient. And so this brings us to the end of the sections that we were covering today. Are there any questions? Let me maximize so that I could see, just in case anyone's removing themselves from mute. No questions? All right, then with that, I know we covered a lot of information. I really encourage you to go back, review your modules, and try to review the ones for next week ahead of time if possible. I find that very helpful. And I'll give one last chance for any questions. Okay, if there's no questions, then thank you very much for joining, and I wish you the best of luck with your studying and preparation for the exam. Thank you very much.